So this video will guide you how to optimally manage a frozen shoulder from a physiotherapy perspective. We will talk briefly about why a frozen shoulder develops and why these changes give you the symptoms you currently have. Understanding this enables you to understand what management plan you should follow in your individual circumstance, because each case will vary. Now, the first thing to understand is some terminology that may be confusing without explanation. Some clinicians may refer to a frozen shoulder as a capsulitis or an adhesive capsulitis. So if you've heard these terms, it essentially means the same thing, a frozen shoulder. Many clinicians will also distinguish whether a frozen shoulder or a capsulitis has come on without a definite cause, which they will term a primary or idiopathic frozen shoulder, or after a known injury or surgery to the shoulder, which they will term a secondary frozen shoulder. Although there is no definite cause with a primary frozen shoulder, we know that it is far more common among women than men between the ages of 40 to 60 years old, and also for people with long-term conditions such as diabetes, thyroid problems, and sometimes cardiovascular conditions. Now, if you're suffering with a frozen shoulder, you will have almost certainly heard about the 3 stages of a frozen shoulder. Again, the terminology may vary, but generally these are termed freezing or stage 1, frozen or stage 2, thawing or stage 3. Many clinicians also simply assess whether a frozen shoulder is pain dominant or stiffness dominant, and the reason why the stage of a frozen shoulder matters so much is that different treatments work at different stages of a frozen shoulder, and if the wrong treatment is prescribed at the wrong time in a frozen shoulder cycle, it may make your symptoms worse. So, what is stage 1 or the freezing stage of a frozen shoulder? Well, during this stage, the soft tissue capsule and ligaments around the shoulder begin to inflame. Persistent inflammation in the shoulder capsule and ligaments, which are normally flexible, leads to the formation of tough, inflexible scar tissue. The result is characteristic symptoms of significant stiffness to shoulder movements and significant resting pain, often felt intensely through the night. It's really important to recognise that unless you have a secondary frozen shoulder due to significant trauma, a fracture, tendon tear, shoulder dislocation or surgery, there is no actual damage being done to the shoulder, but an underlying process of inflammation without a mechanical cause. The reason why this is important is that if any significant exercise or movement is targeted at a pain-dominant frozen shoulder, well, it may make your symptoms worse because it leads to more inflammation, not less. That's why at this stage we recommend gentle, passive movements only. For individuals who find their pain unmanageable at this stage, sometimes clinicians may recommend different forms of analgesia or a corticosteroid injection, which is essentially a targeted anti-inflammatory injection into the shoulder joint. These do all have possible side effects, so should be considered only when necessary with your clinician. Now, once the significant resting and nocturnal pain starts to reduce, this indicates that the active inflammatory process in the shoulder capsule and ligaments has probably begun to reduce. This is what's referred to as stage 2 or the freezing stage, and it essentially marks the transition between a pain-dominant frozen shoulder and recovery of the range of motion in stage 3. At this stage, physiotherapy mobility exercises should be commenced and concentrate on 3 main movements to restore some initial function. These include external rotation, which is needed for reaching to the side and above head, shoulder flexion required for above head activity, and shoulder internal rotation required for reaching behind the back. Now, at some point along this process, the shoulder range of motion will begin to improve. This marks stage 3 or the thawing stage, and the improvements are due to the tough, inflexible scar tissue that formed in the shoulder capsule and ligaments remodelling into more normal, flexible soft tissue. As the shoulder range of motion increases, the stretches and mobility exercises can be progressed into more advanced positions. For individuals who normally function at higher level with their shoulder for sport or their occupation, some strengthening exercises may also be of benefit for them once the range of motion has improved significantly. Now, the time frames from initial onset of a frozen shoulder to resolution vary significantly for each individual. If there is an underlying medical cause such as diabetes, or in cases of a secondary frozen shoulder, this may complicate timeframes. However, most cases of a frozen shoulder will be present for between 6 months to 2 years. A good resolution for a frozen shoulder will be upwards of 90% restoration of the normal range of motion of the shoulder. This is fine for full, pain-free function for almost everyone, and will normally only be noticed when a doctor or physiotherapist examines the shoulder. In some minor percentage of cases, the shoulder range of motion does not begin to recover. In this situation, you should definitely speak with a doctor or physiotherapist regarding further diagnostics and other options to release the motion. This may include an injection procedure known as a hydrodilatation or shoulder capsular release surgery. If things are following a normal course, then please use our helpful playlist and guides for appropriate exercise technique and progressions for each stage.